would like to invite our third speaker, and we will see with Mario Roccuzzo the long-term procedures that you are doing. Please help me to welcome Mario.
Thank you.
Grazie.
Thank you. It's a big pleasure to be here with some friends. It's nice to see so many people inside the room and talking about something which is not so fancy. I mean, we're talking about not implants in a day, in an hour, in a minute. We're not talking about laser. We're not talking about computer guides, satellites. We're talking about simple things, but can really make the difference. Because, you know, I have a perception that when we go to congresses and we see all these beautiful cases, perfect, they are a selection. It's, what about these cases? Nobody talks about these cases. And I know that many of these cases happened because the dentist was too brave, wanted to show off, wanted to go too fast, wanted to prove something. And I am very much in accordance with Ronnie Jung. Be careful, treat your patients as if they are your familiar. Because you know what? Sometimes images hide the truth. If you look at those two videos, you see that Tiger Woods misses the hole and I do it. But I'm bad. I'm a bad golfer. Bad, really bad. And Tiger Woods, of course, was a great golfer. But sometimes in congresses we see this. They make a selection of the best cases and you feel like you are urged to rush. You're urged to do quickly because otherwise you're a loser. Don't believe that. Now, good common sense is also something that should guide us. For example, can we place an implant in the extraction socket in a case like this? Can we? Yes or no? Yes, we can. I mean, somehow, in some way, with some implant, somehow we can do it. But it's that wise. So that's the difference. That's the difference. If we do alveolar ridge preservation, which is relatively simple, we wait 4 months. When we enter, it's very, very simple, so predictable, not only for the bone, but also for the soft tissues. And when you achieve these results at day 1, most of the time, if you do things properly, if the patient is under control, if the implant is properly placed, the results last for many, many years. So you can see here in a case which was treated in 2008, and you have a 15 years follow-up. And I want to show you a study which I did a few years ago. It's not really new, but it's the first study which presented the 10-year results after alveolar ridge preservation. The idea was to assess if the soft tissues around implants placed after alveolar ridge preservation were stable or not. And so the idea was to do the alveolar ridge presentation. After 4 to 6 months, do the implant. At that time, we cemented the crowns. Now we'll be scrutinating, but this is an old study. Patients were seen regularly for the supportive parental care. And then we collected the data at 10 years. And at that time, we did not have metrics. So to seal the socket, we used the double layer of the BioGuide membrane or another sealing agent which is not available in the market anymore. And we wanted to measure the length of the crown at baseline and 10 years afterwards, because this will be a simple method to understand if the recession occurred or not. And this is the control case, as I mentioned before, with the sealing agent, Atrisorb, which is not available anymore. After 4 months, again, look how easy is the crest, a piece of cake. And look at the quality of the soft tissues when we remove the crown to check the soft tissue. Look at the crown, and look at the soft tissue around the color of the implant. To mention the fact that, of course, we don't do cemented crown anymore, but if you do things properly, even cementation is not a problem per se. Cementation is a problem if the implant is not properly placed. How much recession we had? On average, less than 0.5 millimeters, almost nothing. So basically, we were able to prove that, yes, indeed, if you do this, the results are stable for many years to come. Here is a patient who was treated 12 years before. The recession is less than 1 millimeter in 10 years. And we were able to follow many of these patients throughout time. This is a medical doctor who I treated in 2003, and here's the picture 22 years afterwards. And you see there was no buccal bone at all. Now, if you do ridge preservation, you have to do properly. First of all, you have to find the correct indications. And for example, this is a case where it's very much indicated. She's losing her central incisor, and you see the risk factors. She's periodontal compromised patient, she has poor plaque control, she has a fistula, the papilla are slightly missing, there is an endo problem. And the recession on adjacent teeth. Would you go for implants in the extraction socket? No, no way. We do the extraction. We clean carefully the defect. That's very, very important, because if you don't clean the defect carefully, you're going to regenerate fibrotic tissue, not bone. So cleaning is not easy. And you have to fill the defect ideally. Now, I've heard people that use materials which looks like bios, but it's not bios. Well, you can use whatever you want, but don't think all materials are the same. There is a huge difference in the results you obtain. And then you see here, you have to clean carefully, place bios collagen, and seal with a matrix. Now we have these matrix which are purposely done for this purpose, and you suture, and then you place a provisional restoration. Now, what's important in a case like this, that in this time, you have the possibility to educate your patient to clean properly. When they come and they have poor plaque control, you can use the months of healing in order to improve patients' conditions. Again, look at the quality, visually, of the quality of the bone. And here, it's a very simple thing to place the implant. Now, you know that no matter how hard you try, with time, and when I say time, I don't mean 6 months, a year, I mean decades, 5, 10, 20 years, you're going to have resorption. So there are a few tricks. After you do alveolar ridge preservation, you have to place an implant, which is not too big. We don't place implants as big as we can like we did in the past, because we're going to have a little bit of resorption, buccally, no matter what. So on top of our regeneration, we may place some additional bone, additional material, a connective tissue graft, and we make sure you place the implant slightly palatal to compensate for that. If you do that, you suture, the great majority of times you have this type of healing, which is stable. You see, the implant is not too deep. That's very important, particularly in periodontal compromised patients. Healthy tissue. The patient is okay. Look carefully at the soft tissues, both in horizontal and the vertical dimension. And if you look at the picture taken 9 years afterwards, you see there is a little bit of inflammation around adjacent teeth, meaning that she is good at oral hygiene, but not perfect. But if you look at the picture in 2025, 11 years afterwards, you see there is a recession of the adjacent teeth, but not on the implant. And that's something really, really important, of course. You have to stabilize and protect the graft. And as I mentioned before, we use a matrix. Here's another case where, of course, I don't want to do implants in the extraction socket. She's a medical doctor, and her teeth are not really perfect. So we can use the time of healing to promote orthodontic movement. And the provisional restoration will be taken by the brackets. You see that the instrument is way up in the buccal side, so there is nothing there. It's all empty. We fill the defect with bios collagen, and I insist, bios collagen, not the regular one. We suture, let it heal, and you see here that you have not the possibility to obtain 100%. You save 80, 85, 90% in the best scenario, but that's not important, because when we look back at the situation and we place the implant, we can place the implant fully embedded into the bone, and then we can add some bone, some grafting material, some connective tissue graft, depending on the circumstances, and the result are most of the time predictable. You take no much risk. If something goes wrong, it's not going to be a disaster, and most of the time you can obtain good results. Look at the situation, how difficult it is from the study point of view. And if there is a small mistake, it will be so much visible. Why should we risk so much? Don't try to make miracles. Try to be good dentists. Another important factor is not to contaminate the graft. So if we have a case like this, shall we do alveolar ridge preservation? Well, I think it's better to be prudent. So in case of a fracture with lots of pus, I remove the fragment broken, I wait for a while, and then I do alveolar ridge preservation. Of course, it takes a little bit of extra time. The patient will have to come 2 times as much. But I mean, you reduce the risk for such a great amount of time that it's not really, really necessary to take additional risk. And when you do that, again, maybe the implant is not ideally placed, maybe you need a little bit of bone graft, but it's so easy now. And you look at the soft tissue results after 10 years, healthy. And again, the implant position is important because you don't have the tendency to go too deep. Last but not least, in the things to remember when we do alveolar ridge preservation is not to create damage with the provisional restoration. So there are many ways. The only thing I'd like you to think about is not to use provisional restoration which put pressure on the area. Otherwise, you will have some extra resorption. This is a case where a tooth had to be extracted, and in this specific case, I had to use 3 blocks, 100 milligrams of bios. Think how big it was. Of course, I cannot show you because it was flapless, but 3 pieces of bios collagen, which means the defect was huge. We waited 4 months, and after 4 months, we were able to place an implant, fully embedded in the bone. And you see here that it was even done with a cantilever. Once again, no problem. And this is a follow-up at 12 years. Now, it's also important, I think, Ronnie, to tell them when you should not go for alveolar ridge preservation. This, for example, a case, hopeless tooth near another hopeless tooth. So don't get too enthusiastic, and sometimes I've seen alveolar ridge preservation in areas where it was impossible to restore. So we extract the tooth, and we see there is a huge defect along the lateral incisor. It's not possible to be successful with this technique. So in cases like this, you clean the area, you do a ridge reconstruction, in this specific case with a titanium mesh. You can use non-resorbable membranes. But of course, there are times where you cannot preserve. There is nothing to preserve, okay? But with the proper technique, we can even do things like this. It's not easy, but it's possible. Or, in a case like this, is that the premolar, which was fractured, and you see the position, it's right on top of the nerve. Is that wise to do alveolar ridge preservation here? Not really, because the risk is the nerve. The crest is thin. We know that we cannot obtain 100%. So if we do ridge preservation now, we'll be able to find a situation which is not as good as hoped. So it's going to be difficult. So if we want to do immediate placement here, it's risky. You have to be with experience. We take the measure of the root. We decided to go for an implant in the area. We are careful. We graft, no matter what, the area around the immediate implant. Tissues are okay. And then if everything goes well, you can obtain good results. But don't stretch the indication so that you try to solve all the situation with alveolar ridge preservation. And now we can also talk about something which will become more and more common in the future. I see many young people here, and many of you will become in the future experts of implant removals. Of course. Of course. It will be, the big issue 10 years from now. And when we remove an implant like this, we can see there is nothing on the buccal side. You see there is flat. So can we place an implant in the, quote, extraction socket? No. So we apply the same principle. We clean carefully, and cleaning this with no bone is not easy, but we can do it. We fill the defect. We seal the defect with a matrix. Mucoguide seal, it's mucograft seal. It's purposely created for this indication. And then we do the X-ray a few months afterwards. You see that it's not perfect, but it's more than okay. It's almost perfect, 85, 90%. And there's a little bit of concavity, but it's not much. Placing the implant here is simple. We are happy because the soft tissue is thick, and she's happy with that. Last but not least, if you apply the principle of alveolar ridge preservation to complicated cases, you can even save lots of surgeries to one of your patients. So we have a case of a young lady who had an accident in 2006. Look at the disaster. What to do? If she came in the department of maxillofacial surgery in my hospital where I work, they would probably go for general anesthesia, bone from the hip, big reconstruction. But if you think carefully, she is now in the situation of an extraction socket. So what can we do? What can we do? We can do alveolar ridge preservation first. And then we try to keep the canine, even if it's broken, just to hold the position. Then we can do a sinus lift, remove the wisdom tooth, and we can place 2 implants. And then we can do alveolar ridge preservation for the canine, not because we want to place an implant there, but because we want to keep the volume. And then we fill the defect for the canine. And then we go back to the position of the lateral incisor when we did alveolar ridge preservation a few months before, and we place the implant there. And if we are lucky, we can go from here to here. 2 ridge preservation, 1 sinus lift, implant placement, and everything was solved. Everything was solved with time and patience. And if you do that, look at the beauty of the papilla around implants which are properly placed, as shallow as possible, as deep as necessary. And if you do that, and the patient is under control, and she comes regularly, and everything, of course, is decent, you can obtain good results. So indeed, I'm with Ronnie stating that, just a memory of how we started. Alveolar ridge preservation is a dentist and patient-friendly technique with low risk of major complication. Something can go wrong, but it's never going to be a disaster because you have different steps. It's proven to facilitate subsequent surgical implant placement, which will make your life much easier. And with this, I thank you for your kind attention.